I am Dr. Vinay Sakhuja and I am currently working as the Director of Nephrology and Transplant Medicine at Max Super Speciality Hospital, Mohali near Chandigarh. I will be speaking to you today about the management of patients with end-stage renal disease, that is those individuals in whom both kidneys have irreversibly been damaged and have lost their function. Such loss of kidney function frequently occurs in patients with long-standing diabetes mellitus, in those with severe or long-standing high blood pressure, in patients with disease of the kidneys that involves stone formation in the kidneys, or in conditions like chronic glomerulonephritis. Now, in patients who have had irreversible damage to both kidneys, there are two ways in which these patients can be managed. Firstly, they can either be put on dialysis, and the second way that they can be managed is by kidney transplantation. I'll first tell you briefly about dialysis. There are two techniques of dialysis, namely hemodialysis and peritoneal dialysis. Hemodialysis is a process in which the blood of the patient passes through a machine which purifies the blood and then returns it to the patient. This process has to be carried out at least 2 to 3 times a week and for 4 hours at each session. For the purposes of hemodialysis, one has to gain access to the patient's circulation, and for that a minor operation called an AV fistula has to be performed on the forearm of the patient. This makes hemodialysis easy and painless to perform. While on hemodialysis, the patients need to continue their blood pressure medications, and they also need to monitor their urine output and ensure that their fluid intake is according to the amount of urine that they are passing and is not excessive. In order to maintain the hemoglobin levels close to normal, they need to receive iron and folic acid supplements, and in addition they need to receive certain injections which are given every week or every 2 weeks in order to maintain the hemoglobin level. It's also important to avoid as far as possible blood transfusions in these patients because of the risk of transmitting viral infections such as hepatitis B and hepatitis C in these patients. Such patients also need to be vaccinated against hepatitis B. Ideally, this vaccination should be given well before the start of maintenance hemodialysis. In addition to the hepatitis B vaccine, they should also receive a single dose of the pneumococcal vaccine. The other form of dialysis that patients can be put on is peritoneal dialysis. For this, a catheter is inserted surgically into the abdomen through the abdominal wall. Part of the catheter is outside the body permanently. Through this catheter, the patient can be trained to perform peritoneal dialysis by himself at home and this is one of the advantages of peritoneal dialysis over hemodialysis, that the patient does not have to go anywhere else to get the procedure done. It can be done at home itself. However, the procedure has to be done 3 times a day. So at each time, 2 liters of a special kind of fluid is put into the abdominal cavity, and 4 to 5 hours later, this fluid is drained out and a fresh 2 liters of fluid are instilled. This form of treatment has the disadvantage that it is slightly costlier than hemodialysis, and there is a greater risk of infection while performing this kind of dialysis as compared to hemodialysis. The other kind of treatment that is in fact the best treatment for patients with end-stage renal disease is a kidney transplant. This is superior to any form of hemodialysis because of the exceptional quality of life that the patient can achieve after a successful kidney transplant, which is not possible on maintenance dialysis. A kidney transplant should ideally be done using a closely related kidney donor who has a matching blood group. Using a closely related donor enhances the success rate of kidney transplantation. Patients, of course, have to be on a 3-drug regimen which is started just before transplantation and continues lifelong thereafter in order to prevent any damage to the transplanted kidney by the process of rejection. These patients need to be on regular follow-up by a nephrologist. They are at an increased risk for some infections, and proper preventive measures need to be taken to reduce the risk of such infections. Following a successful transplant from a closely related donor, the kidney can be expected to function for more than 10 years in more than 80% of such transplants. So the results of such transplants are quite good. When a live donor is used for such a transplant, the donor does need to undergo surgery. However, the surgery is done by a laparoscopic technique so that the pain that the donor suffers is minimized. The hospital stay for the donor is only about 5 days and the wound heals quickly. Of course, before taking up the donor for surgery, several tests are done to ensure that the donor is fit to donate a kidney and will not be at any risk immediately after donation or in the long term. So kidney donation is quite a safe and harmless procedure. In case a closely related donor is not available, then one can consider using a distant relative or a friend with a matching blood group as a kidney donor. This, of course, requires permission from the authorization committee of the state where the transplant is being performed. In case no live donor is available for a particular recipient, a cadaver donor, that is a donor who has already suffered brainstem death and is being kept alive on a ventilator, can be used as a source of a kidney if his relatives do grant permission, and the results of such transplants are only slightly inferior to those of kidneys taken from a closely related donor with current forms of immunosuppressive therapy.